So the next session is top 10 questions about IgA nephropathy to ask the experts. And in that respect, the experts are Professor Jonathan Barrett and Dr. Chi Chung, both of whom know as much about IgA nephropathy as anybody out there. Where's my list of questions? I've just lost the list of questions now. So what I did was I sent out a message on the Facebook page and said I was going to do this session, and could people put their questions onto the Facebook page, and I would then put them to the experts. If you've got any more questions while we're going through this list, and if we've got time, then put them on the chat. I'm happy to put them to John and Chike. And also, if we don't have time to answer them, I will always make a record of those questions and then put the answers on the Facebook page, so they will not be lost in the system. So if you've got any questions, just let me know. So Chike, for the first question is, I haven't put any names here, so I'm just going to say a person. Asked, in the UK, many IgA nephropathy patients are managed by their GPs. But in the light of new treatments becoming available, should patients request a referral to a renal consultant to discuss medication to slow down the decline of their renal function? So answer to that question, and also a practical answer to that question, like, would they be able to do that? Nice thing to be able to do. Can you ask your GP to do that?
Yeah, so it's a good question. I think obviously every individual case is different. I would say in Leicester that we have very strong links with our GPs, so that we can communicate with GPs frequently, both by phone, electronically, by email. But for sure, I think if patients have any concerns or queries, then they should very much raise those with their GPs. And again, I personally would be happy to be contacted directly if I can help with anything at all. I think the question about progression of new therapies, obviously it is a changing field rapidly, so I think if patients have any concerns, then for sure they should raise them, and we'd be happy to communicate either directly or with GPs. John, do you want to comment on?
Yeah, I mean, I think I'm very much of the opinion that we need to empower patients to be able to access the services that they need. So I think if you have IgA nephropathy and you're being looked after by your GP, that may be completely appropriate, and it may be that you're not. It's not appropriate for you to have any additional therapies, but you need, your GP probably only has one IgA nephropathy patient on their books. So you can't expect your GP to be an expert. They can be an absolutely great doctor, but you can't expect them to be an expert on every rare disease. So I think there you do need to be going and looking for specialist opinion. And I would completely support you to ask for a discussion with a nephrologist to go through what the options are. And as Chike says, we're very happy to facilitate that.
And do you think that's the situation across the country? You know, bearing in mind that in Leicester, everyone's very keen about IgA nephropathy. If you live in Exeter, just the first city I can think of, will that still happen?
I think nephrologists up and down the country are very happy to see patients to give advice and guidance. I think it's worth remembering that there was a vogue 5-10 years ago to try and discharge as many patients from clinic as they could across the NHS, and therefore patients with IgA nephropathy who kidney function was changing only very slowly, a lot of units decided to discharge those patients to their GP and ask the GP to carry on looking after them. Now, that was because there was nothing else that was available for them at the time, but the situation clearly is changing. And so I think it is absolutely appropriate for their clinical course to be reviewed to see whether now is the time for new treatments that didn't exist at the time they last saw a nephrologist.
So the second one, John, I'll go to you. So somebody wrote this message and he said, could the biopsy have picked up endometriosis tissue and not IgA? I'm presuming that's when they've done the kidney biopsy.
Yeah, so I think that wouldn't be the case. So for those of you that don't know, endometriosis is a condition where cells from the lining of the womb move away from the lining of the womb and move into other parts of the body. and normally they move into the abdominal cavity. And just during a lady's normal cycle, they can change in the way that the womb changes. So they can develop, and then just as the womb sheds its lining, those cells can be shed, and there can be some bleeding inside the abdominal cavity, and it can cause a lot of pain and discomfort. Because the kidneys actually are not in the abdominal cavity, they're very much at the back, behind what we would call retroperitoneal, which means they're actually in the tissue of the back and not free floating in the abdominal cavity. I would say it's almost impossible, if not impossible, for these cells to actually get anywhere near the kidneys just because of the anatomy.
Right. Okay, that's quite clear. Thank you very much for that. So, Chike, somebody asked, can I take non-steroidal anti-inflammatories when my kidney function is over 90% and has remained so for 8 years?
That's a good question as well. So I think my approach is that we know that non-steroidal NSAIDs, or non-steroidal anti-inflammatory drugs, are associated with side effects, especially over the long term, regarding progressive kidney damage and other side effects, for example, irritating the stomach lining and so on. But that risk of progressive kidney damage probably is increased with more advanced stages of kidney disease, so you have far more risk of that. For example, if you have GFR less than 60, and that risk goes up with that degree of kidney damage. So I think if somebody has a very preserved kidney function, then personally I would feel comfortable with that patient taking the occasional dose. They may have a very good reason for taking that medication. It's just to be aware that longer term use is associated with worsening kidney function, and especially to bear in mind that NSAIDs may interact with other medications as well.
So would you recommend they spoke to a doctor about it?
Yes, I think it's always wise to get medical advice for that.
Right, and would their GP be appropriate, or do they have to go to their consultant?
I think either would be fine for that.
Okay, great. Okay. Right. So I've been told, not me, this is the question. I've been told that IgA nephropathy is not hereditary, but there is some sort of genetic factor which can make some be predisposed to it. Is it true? And if so, what do we know about this? If the genes have been identified, can we now test for this? John, can you answer that question?
Yes. So again, a very good question. One of the things I would suggest is if you are interested, Danny Gale does a really nice talk on the genetics behind IgA nephropathy, and that's on the YouTube channel. But the top level is that there are some very rare families where IgA nephropathy does run in the family. And by that I mean brothers and sisters are equally affected, children, nephews, nieces, so very close relatives. There are a lot of family members that are affected. In my clinical practice, I would see one person with IgA nephropathy where that has happened for every 200 to 300 patients where there's no history of any family or other family members having IgA nephropathy. So it is a very rare event, but it does happen. And there are studies from families around the world where people have looked in great detail at the genetics behind this. And unfortunately, they haven't been able to find the genes, even in these families, that have caused the IgA nephropathy. So in the vast majority of people, there are genetic factors that do contribute a very, very little amount to the risk of you developing IgA nephropathy. But that amount is so small that actually measuring those genetic factors would not help me to say whether you are likely to have IgA nephropathy or not. Because what we're talking about are genetic factors that have been identified in cohorts of 5, 6, 7, 8, 10,000 patients, which on average are associated with IgA nephropathy, but don't really give us a handle on an individual level. So there are genetic factors that do contribute to development of IgA nephropathy, but each of them contributes only a very little amount, and therefore they're not useful at the moment to be used as a test, either for your kids or for other people to work out whether you're likely to get IgA nephropathy.
So it's useful to know that there is this small element of genetics, maybe in the future, maybe the more we understand about IgA nephropathy, maybe that can contribute, but only in a small way.
Yeah, I mean, my guess will be, in the fullness of time, we may identify 100 different genes that each a very little bit contribute to the development. So if we're going to be doing a genetic test, it would involve many, many different genes looking at this. There's no one gene that we can test like other kidney diseases, like polycystic kidney disease, where we can do a test, we know exactly what we're looking for, and we can make a diagnosis, or we can tell whether a family member may or may not have that condition. In IgA nephropathy, we're not going to have that, I think, in the next 5 to 10 years. It's just because there'll be so many different genes, all doing a small amount of having a small amount of contribution.
Okay. Great, thank you very much. So, Chike, for women with IgA nephropathy, are there established links or research into hormonal issues, for example, polycystic ovarian syndrome, early perimenopause, hormonal imbalances, etc.? Do you know there's any contribution to things like that?
I think there is research going into these factors all the time. I'm not aware of any specific links with IgA nephropathy and those certain conditions, but we do know that chronic kidney disease itself is a risk for example, early menopause, and again that goes with the more advanced. The risk increases with the stages of chronic kidney disease. So it may not be the IgA nephropathy, but more the consequence of having kidney disease in general. So we think of IgA nephropathy more as being an autoimmune disease now, with antibodies being formed to the IgA, and maybe some autoimmune diseases grouped together as well. For example, with thyroid disease. The interesting links, they're still being looked into in a lot more detail by research groups. And again, I think as John alluded to before, not everybody with IgA nephropathy is going to be the same. People, it's a very variable disease, and some people may have some forms of the disease and others be quite different as well. So lots of research going on at the moment.
Right. So yeah, we can't answer that question quite. There's not enough.
So Karen, the only other thing I'd add to what Chike has said is that what's interesting is in Caucasians, the disease is 3 to 4 times more common in males to females. Now, we don't know why, but that could be related hormonally, because clearly the hormonal profile is different. We lose that when we go into Asia, where it's as many males as females are affected. So it could be that in our population, the hormonal background may have some factor to play in IgA nephropathy, but as Chike says, we really don't have a grasp on what that is at the moment.
Right. Okay. Great. So John, back to John. And I don't understand this question. So, could HELLP syndrome during pregnancy have caused IgA nephropathy? So, and if you could share what HELLP syndrome is first, that would be great.
So HELLP syndrome is a form of something called preeclampsia, which happens at the very late stages of pregnancy, and to my knowledge has not been associated with IgA nephropathy. It's a very, very different process. So the HELLP stands for hemolysis, so your red blood cells break up, and your liver becomes very abnormal as well, but it usually gets better after you've delivered the baby. Now, the really interesting thing, and I don't know for patients on the call, but because IgA nephropathy does not give symptoms, the most common way we diagnose it is by people having their urine dipped and us seeing blood and protein in the urine. And if you think about it, for a lady, when is the most likely time that you ever have your urine dipsticked? And ladies all have their urine dipsticked when they're pregnant because of the worry of picking up urinary tract infections. And so we do find a lot of patients who come to our attention who never knew they had IgA nephropathy around the time of pregnancy, because then people are looking out for things and they pick things up. And so I don't know this particular case, but it could have been that actually, because the lady was pregnant, because they found these abnormalities it brought to the attention of the medical profession something that was going on that wouldn't ordinarily have been noticed. And clearly HELLP is a very serious condition, and that would have made us want to investigate things in more detail, and may well have picked up an IgA nephropathy disease that had always been there actually, but hadn't been causing any symptoms. And actually, if the lady hadn't become pregnant, she probably wouldn't have known about it. The other thing to say is, if you have underlying kidney disease, you are more likely or at greater risk of developing preeclampsia. Right. So the two could have been related, but more from the fact that the underlying IgA nephropathy increased the risk of you developing this condition, but they're not related in terms of understanding the underlying disease. And again, there's a great talk from Kate Bramham on the YouTube channel that deals exclusively with pregnancy in IgA nephropathy. And Kate is probably one of the world's best experts of pregnancy and kidney disease. So I think the likely scenario is this lady probably had IgA nephropathy all along. It increased her risk of developing the HELLP syndrome, and actually came to light because people were taking much more attention and focusing on looking at her urine for the pregnancy reasons. And this is this is how the diagnosis was made. Yeah.
So and just to say that video about pregnancy and IgA nephropathy, it's actually a very reassuring video. So it was on one of the previous information days, and we videoed it, so I've seen it. And she's not going to say, if you listen to it and you're thinking of being pregnant with IgA nephropathy, she doesn't say don't get pregnant. She
not at all. Not
practical
at all.
advice, doesn't she?
Absolutely. And I think just like every other renal unit, if you do have IgA and you want to plan a family, then the important thing is to chat to your kidney doctor, because the important thing is for you to meet with the obstetricians and the kidney doctors to talk through with your particular information about how much protein there is in the urine, what drugs you're taking, what your kidney function is, what that means for you and your baby in terms of the pregnancy. And so we do something called preconception counselling, and we offer that service with a renal obstetrics clinic. And I would thoroughly recommend any ladies on the call who are thinking of having a baby, that's absolutely not a problem in IgA nephropathy, but you do need to have a little bit more attention paid to you, and you need to have the opportunity to chat through what that means for you as an individual based on your clinical situation at the moment.
Yeah, arm yourself with information. Right, Chike, could I ask you, are there any restrictions you would recommend to IgA nephropathy patients about exercise, in particular intensity and duration?
I don't think there are any particular restrictions, obviously, that I can think of within the limits of sensible advice that I would think would be advisable to everybody, really. There's been a lot of research with exercise and kidney disease. We know it has very beneficial effects, and I don't know, I think there are videos of exercise and kidney disease on the YouTube channel as well.
Yeah.
So no particular restrictions, but obviously every case is different, yeah, that's right.
Okay, and because I think sometimes people are concerned that it's going to raise their blood pressure, because treatment for IgA nephropathy is about controlling your blood pressure, isn't it?
Yeah, absolutely. And it's important that obviously people's blood pressure is controlled, and if they feel unwell when they're doing the exercise to stop and maybe get advice if they're getting any effects or symptoms that they're worried about when doing exercise. Yeah,
but the point but the other side of that is you wouldn't say don't do exercise. It's better to be healthy, isn't it? It's better to do exercise even with IgA nephropathy. And that comes over, like you said, there is a video on the YouTube channel about exercise. So no excuse not to do exercise. So the next one was a sort of very vague, John, and it was understanding the impact of protein/blood in the urine and treatment options. I'm not sure how to answer this one. I copied it directly from the Facebook page. So.
Yeah, so blood and protein in the urine is the classical sign that we look for in patients with IgA nephropathy. And the key thing is that we base the decisions on how we look after you based on the amount of protein in the urine.
Yeah.
And then we will use that to determine the risk of what's going to happen in the future and guide our therapy.
So it's not to be ignored. It's something to be discussed with you.
And again, this is just a call out for patient view. So if you register with Radar, which is what Harish was talking about, you can register for patient view. It's going to change its name to Patient Knows Best, but this allows you to access on any device your blood results that you have in clinic, and you can see your own results. They can be mapped out on a little graph that shows whether things are going up or down, and you can access that 24/7. So if you don't know about Patient View, then please get in touch. It's completely free. You need to be, you register with Radar and you register for Patient Knows Best. You can do this all online through the website. And there will be a process whereby your local kidney centre will be contacted to say, are you really a kidney patient at that unit? And they'll just have to say, yes, they are. And then you get a login and a password. And it's a great resource if you don't have it already to be able to track your results, if that's what you'd like to do. So often my patients will know their blood results and urine results before they see me, because they'll have had their blood done the week before. It'll be on the system. They'll be able to see them. And then when they come and see me, they already know how things are.
Yeah. So I don't know whether this is too open, but the other part of the question was treatment options, or is that to
So I think, so as we said, everyone should have their blood pressure controlled. Everyone should be on an angiotensin receptor blocker or ACE inhibitor. So, and we need to make sure that we address lifestyle issues, such as Chike was talking about exercise, being a good weight, not smoking, and think about those kind of general issues. And then if the protein level is still high, my first option, as I said in my little talk, is I will offer that patient a clinical study, because I want to offer them the opportunity to be in a study of a new treatment. And as you've heard, at the moment, I don't really have anything else to offer, because I don't use corticosteroids, so prednisolone. Some people do, some people don't. I personally don't, because I'm concerned about the toxicity of those drugs. But over the next couple of years, I will have new therapies to choose from. So I think the situation is going to change. The exciting thing is there will be fantastic new treatments available. At the moment, my preference is that I offer all my patients recruitment into a trial.
Okay. So just point out that Matt Graham-Brown has put on the chat, he's put the link to the video that's on the YouTube channel that explain medical terms we use and what they mean, including terms that deal with blood protein in the urine and the significance of it. So if people want to know some more information, that's all. That have a look on the chat. That would be great. The next one, Chike, how does COVID affect IgA nephropathy? Now COVID is endemic, how does this have an impact on patients who are immunosuppressed? That must be a real worry for patients with a transplant.
Yes, it is a real worry, and I think we do know there's good evidence now that if you take immunosuppression, you are at increased risk of worse effects from COVID, and that is increased if the immunosuppression is heavier. And also kidney disease is a risk factor for worse outcomes from COVID as well, with more advanced stages of kidney disease. For example, if you have stage 5 kidney disease or you're a dialysis patient. So I think obviously, fortunately, we've had vaccines now. There's good immunity to try and reduce those worse outcomes. But certainly, if you are in one of those high risk groups and you do develop COVID, it's really important that you let your doctor, your kidney doctor, know straight away, because you might be eligible for some of the early treatments for COVID. And there's lots of good information out there about this. I think on the Kidney Care UK website, where people can look at that. I think in more general terms about IgA and COVID, I don't think there's really very strong links between COVID worsening IgA disease that I've seen. Certainly, COVID can cause an acute kidney injury, acute drop in kidney function. That risk is increased if you have kidney disease already, but no clear links between COVID and IgA nephropathy. But again, it's a rapidly progressing field of research, and we may know more in the future.
Okay, thank you very much for that. So the next question on my list is about different blood pressure medications and their side effects, and when and if they should be changed. Would that be covered by one of the videos in the YouTube channel, John, or would you like to address it now?
Well, I think in brief, different people respond to different tablets in different ways and experience different side effects.
Right.
So I think it's really important when you're started on a new tablet. What we tend to do is start at a low dose and slowly increase the dose and watch out for side effects, because all tablets do have side effects. And then we find a dose that is suitable for the patient in front of us in terms of how good that is at lowering the blood pressure, but also how tolerable it is in terms of the side effects. And then if we haven't achieved the target blood pressure, we'll add another drug. So we can get away with treating, we may need 2 drugs to treat the blood pressure if the maximal dose of one drug is just associated with too many side effects. And as an example, amlodipine, I use amlodipine a lot. It's a certain type of blood pressure medication, but its commonest side effect is puffiness and swelling of the ankles. And so some people can tolerate the full dose, some people can tolerate only 5 milligrams of the tablet when the maximal dose is 10. If I put them up to 10, I get perfect blood control, but their legs swell and the patient doesn't want to have that. So I'll drop the dose and I'll add in another drug at a low dose to get that blood pressure where I want it, but I'll only be able to do that and keep the patient happy by using 2 drugs rather than 1. And this requires a bit of time and effort by your kidney doctor or your GP to find that right combination. And the right combination is different for different people. So it has to be very much individualized. And again, you know, why would we want to give you a tablet that makes you feel worse than you do already if you've got alternatives available? And we do have alternative ways of treating blood pressure.
So I think that came up on one of the videos, isn't it? If you don't get the treatment that makes you feel better, go back and ask, because there'll be alternative ones.
Yeah, there are always alternatives. But I think we have to be honest here. There is no drug I know that isn't associated with some form of side effect or other. And I can give everyone on this call exactly the same dose of a single drug, and some of you will be absolutely fine with it and others of you will have side effects. And we're just not clever enough at the moment, to be quite honest, in predicting often who's going to have the side effects, such as swollen legs with amlodipine. So I'm afraid when we first start treatments, we warn patients of the potential side effects, and we just say, well, if you get it, we're going to have to change it. But I can't tell you whether you're definitely going to or definitely not going to get it. We just have to wait and see.
Okay. I have got a few more. There are some more questions, about 3 more. There's some more questions on the chat as well. But I'm aware that we probably need a little bit of a break. So what I'll do is I'll collate these questions and then get the answers from the experts, and then I'll put them back on the Facebook page. I hope that's okay with everybody, because I think we all need a little bit of a break now. That's okay. So we're due to come back